I believe that the background for discontinuation in CML patients started with a suggestion by Professor John Goldman. So after the observation that some patients that underwent allogeneic stem cell transplant can live with a small molecular residual disease but without overt relapse. So then this suggestion was translated into clinical practice with the first program of discontinuation, so namely the STEAM1 study by the French group, and then again translated into clinical practice, so the so-called treatment-free remission. So we now know that we can discontinue patients after 2 years of stable and deep molecular response, so means MR4 or MR4.5, so undetectable according to the international scale. It's a safe procedure because very, very few patients have been described with progression. And we know also that the relapse that was considered for the threshold for relapse is the loss of a major molecular response. The period in which we see more relapses is the first 6 months. Usually is the most dangerous, so in fact is strongly recommended to monthly monitoring the molecular residual disease during this period. It's still a matter of discussion because, for example, the NCCN guidelines suggested a monthly monitoring for the first 12 months, but I believe that in clinical practice is also feasible the flowchart of monitoring of molecular residual disease suggested by the EuroSKI trial. So this big and huge trial because enrolled more than 700 patients with CML that discontinued the treatment and suggested to monthly monitoring only for the first 6 months, then every 2 for the rest of the first year, and then again every 3 months as always we perform during the routinely clinical practice. Recently, the Australian group suggested also that after that we can perform a 2-month monitoring from the start of discontinuation. It seems also feasible and safe. Until now, only 2, so the median time of duration of TKI treatment, so estimated being more than 5 years with imatinib, probably 3 years with second-generation TKIs when started as a frontline treatment, and the median duration of a deep molecular response, so usually more than 2 years of stable, so without molecular fluctuation over time. Other factors such as age, for example, or the so-called risk at baseline was never confirmed by the univariate analysis of the EuroSKI trial. So in our molecular lab, we tested another tool for the molecular residual disease monitoring that it was called digital droplet PCR. This is more sensitive as compared to the quantitative RQ-PCR used usually routinely in molecular monitoring because it doesn't need a standardization curve. And we retested 50 patients that are at the level of undetectable MR4.5, and we found that 22 of them indeed were still positive for molecular residual disease. So then we followed all these patients after the discontinuation, and of this positive cohort, 11 relapsed soon after the median time of 3 months, as compared indeed only to 4 patients out of 28 that were negative with droplet digital PCR that relapsed after a median time of 6 months. So our conclusion are that probably these methods are more sensitive and that predict the successful outcome after the discontinuation, so we can stratify the patient according to the molecular residual disease that can attempt this type of strategy.